Now, life isn't always straightforward when we're doing arterial embolizations for high flow vascular malformations. Here is one neonate who was in cardiac failure, and here actually is part of the arch study. You can see actually that the brachial artery here is nearly as large as the aortic arch. And when we get our catheter down the arm, you can see that there's this huge conglomeration of abnormal vascular structures here, and from this is a small median artery that actually is the dominant supply to the forearm and hand. And unfortunately, with embolization, this was the result. The actual infant came out of cardiac failure within a few hours. Actually, it responded very well, but the problem was the extensive tissue destruction necessitating amputation. This baby may well have required, without any of this, would have required amputation, but you can see that it can be really challenging and really difficult. And one of the things from a practical standpoint is the entry to do this, so the vascular entry might be significantly smaller than your target. So the femoral artery is significantly smaller than this brachial artery. But because of the tortuosity, it can be really difficult getting your catheters down and treating this. So sometimes some percutaneous treatment will help, but the problem here is that it was really very, very difficult to localize the origin of this median artery when we were doing the treatment, and because of that, obviously, some of the alcohol went further downstream and caused significant tissue destruction. So there are extreme challenges at times. Fistulas are actually different. We hopefully can cure fistulas, particularly if they're very straightforward. And here's one groin fistula between the femoral artery and femoral vein. And fortunately for us, the iliac veins actually are occluded here. So we can easily come from the opposite side with a 4 French catheter, and through that 4 French catheter, we can actually put a small microcatheter down into the fistula, put some microcoils, and here's actually the run afterwards showing flow just down the SFA and profunda without filling of all of these venous channels because of the fistula. So you can actually, even in newborn babies, you can actually close fistulas. This baby was about 6 weeks of age. Complex fistulas, however, are really different. And this is a boy, actually a teenage boy, a 10-year-old boy who's recently undergone a fempop bypass with us because of his fistula in his leg. And we did a lot of angiography to define the fistula. This is his MR angiogram, and you can see how complex this is. And the fistula actually was coming from the SFA. Although there was patency with runoff down into the lower limb, the venous end of the fistula down to the venous end connected with the popliteal vein and the short saphenous vein, and it was very complex, and we decided the best option for him would be surgery. And this was some of his angiogram. Here's some of the femoral injection. Here's part of the fistula coming down to below the knee, then actually connecting, you can see this drainage actually into the long saphenous as well. And here's the upper end of the long saphenous. The long saphenous was significantly arterialized, and it was really difficult. We weren't going to put in covered stents. He was 10 years of age, and he actually underwent a fempop bypass. They used the long saphenous from the other side, and this is him actually just 2 weeks after surgery, and he's doing well. So we wait. I said there's no cures for peripheral arteriovenous malformations. So likewise for him, we will wait and see what the outcome is when we follow him up, and do, if hopefully he will not require any further procedures. So this is a quick I've got. It's a bit hot off the press, and we've never done one quite like this before, so I wanted to show you how we actually used laser and some glue injection to close a fistula, which was predominantly intraosseous in the tibia. And this boy came to us the first time he's ever presented to us. He's 15 years of age, and he was having chronic pain in his leg, which he'd had for about 6 months. There was no history of trauma, and he was otherwise perfectly healthy, and he did not have Parkes-Weber syndrome. When you actually looked at him clinically, you could feel that there was a you could feel there was a thrill in his calf. His calf was hotter, very pulsatile. And here is the MR angiogram. And you can see on the MR angiogram there's rapid filling back into a dilated long saphenous vein. This is mirrored on the angiogram. Here's his runoff below the knee. You can see some abnormal hypervascularity and this fistulous connection here. This fistula actually was straight through the cortex of his tibia, and here is the drainage into enlarged long saphenous vein. And then when we actually did some selective angiograms into the runoff channels beneath the knee, we can see communication with the fistula from all three vessels. So what we decided to do was to treat the venous end of this, because we really couldn't get down to it transarterially. And if any of you have got any other suggestions, I'd gladly receive them. Please tell me. But what we decided to do was come down his long saphenous vein with a catheter inserted from the end. We did some venography. Here is the bony defect in the tibia. We went down right into the bony defect, did some venograms, measured what the diameter of the defect was just for our own interest, and we decided we were going to glue the connection actually through the tibial defect. I actually at one point thought of putting an Amplatzer plug in on the venous end, but then when I realized, he's going to be able maybe to feel this Amplatzer plug as well there. Going to be particularly comfortable perhaps for him. And he's 15, he was playing sports. In fact, he stopped playing all sports. He had a job on a Saturday working at a local supermarket. He had to stop doing that. He couldn't walk around the supermarket because of the pain with this. And so we injected glue, but actually we were a bit concerned that we may actually lose some of the glue up his long saphenous vein. And so what we decided to do was laser up the long saphenous. So we lasered the long saphenous, and then we injected, we left a small portion of this out being lasered. We went straight percutaneously with a 22 gauge needle, injected contrast initially, and you can see some filling of all these small serpiginous channels which actually connect from the arterial side into this fistula, and then we injected glue. And this didn't actually take very long to do. And so this was the angiogram before the gluing and the laser, showing the communication through the fistula, and this is it afterwards with good runoff. So we've not done a case like that before, although we have occluded venous flows, but we've not used the laser. Now the laser didn't probably make much contribution, but it provided us with an element of safety, we thought, for the glue. So there are other high flow vascular anomalies that we see in pediatric practice which you don't see in adult practice usually, and these are the high flow anomalies related to shunts in vascular tumours. I'm not going to talk about the hepatic hemangioma, shunts leading to cardiac failure, because we'll do that in the very last talk, but there are the infantile hemangiomas and the Riches actually, which can give rise to high flow with vascular shunts that sometimes need treatment. There are a few quick tips for vascular tumours. Don't forget that tumours can involute, and actually the involution can be induced by angiogenesis inhibitors, which include steroids. So if you're asked to do any embolizations, for example, vascular tumour, if it's an infantile hemangioma, say a massive parotid one, and the child's got some elements of cardiac failure, or liver hemangiomas, don't forget they need medical treatment with angiogenesis inhibitors. The purpose of the embolization is to close the shunt. You need to involute the tumour as well, and to help, you need to combine it with medical treatment. To put this all into perspective, very, very few vascular tumours require embolization treatments, probably about less than 1% actually, and there are specific indications. And if, like in the liver hemangioma, shunts leading to cardiac failure, don't leave it weeks and weeks before you do the angiogram, before you do the embolization, waiting for the steroids to work, because these children can deteriorate. It's best to get them on steroids and do the embolization early, irrespective of age. You don't need to wait at all.